had the presentation, and Dr. Yaffe is part of that, with the technical briefing on modeling. And we had the new numbers, and I'll comment about that in a moment. As of course, it was sort of a mixed message. We had some evidence that we had flattened the curve and peaked in some ways. In other ways, we still have some more issues and data and period pending to see if we can further make progress in regards to both long-term care and at the community level as well. But I'll comment on the moment. But first, I'm going to hand things over to Dr. Yaffe for today's numbers and some comments on long-term care.
Okay. Thanks very much, Dr. Williams. So again, this is starting with the data from IFIS, Integrated Public Health Information System. The data from public health units as of 4 p.m. yesterday. Total of 11,735 confirmed cases of COVID-19 have been reported in Ontario, representing an increase of 551 cases from the previous report. And almost 57% are female, 44% are 60 years of age and older, and almost 60% are from the Greater Toronto Area. We've had a total of 622 deaths, unfortunately, which is an increase of 38 deaths from the previous day. We do continue to see an increase in the number of resolved cases. We're now at almost 50% of cases, 5,806 have resolved. The number of healthcare workers who have tested positive is 1,368, which is 12% of the total. This is a cumulative number, so it's the number from the beginning. It does not represent the number currently positive. We have 859 patients in hospital. Of those, 250 are in the ICU, intensive care unit, and of those, 194 are on a ventilator. In terms of our lab testing, we have tested 174,170 people in Ontario. Currently, just over 5,500 are under investigation, and in the last 24 hours, we have tested 9,330 specimens, or 9,330 tests have been done. So, as you heard, and Dr. Williams mentioned yesterday, the modeling figures were announced. And again, modeling is prediction of the future, and it's not the actual real numbers. So I'm going to be presenting the actual data, particularly for long-term care. We are cautiously optimistic about community spread, but of course we need to continue with public health measures. But the spread in long-term care and other congregate settings seems to be growing. So, as I mentioned previously, there are different databases used to collect the details around outbreaks in long-term care homes, and every database has strengths and weaknesses. And we use them all to help understand what's going on in terms of the disease, its spread, and public health actions. But today I'm going to use the numbers that have been provided to us by the Ministry of Long-Term Care, because they're probably the most timely data. So as of 3:30 p.m. yesterday, we've had 128 outbreaks reported in long-term care, which represents about 20% of long-term care homes in the province, 399 resident deaths, and 1 staff death. 1,618 positive residents, confirmed positive cases, 867 confirmed positive staff. Now, we do continue to work hard to ensure the implementation of the critical measures to prevent further outbreaks and deaths in long-term care homes from COVID-19. And just at a very high level, those measures are enhanced and expanded testing, both for symptomatic and asymptomatic contacts of confirmed cases. Approximately 10,000 tests have been completed already, which includes more than 3,000 tests done just over the past weekend. Secondly, providing on-site public health and infection control expertise and ensuring that staff have the appropriate PPE, protective equipment. And last but not least, redeploying staff from other settings like hospitals, home and community care to support the workforce in long-term care. At this point, over 400 requests for staff have been made by long-term care homes, and all matches for this have been approved and actioned. So that is at a high level, and I'm going to turn it back to Dr. Williams now.
Yes, well, thank you, Dr. Yaffe. And the modeling was very informative and gives an idea that as far as our intensive care and our critical care, it looks like we have peaked. As far as the community data, we're trying to understand how we are and where we're at in that regard. We know that from the long-term care side, which is a different event that seems to be occurring. The modelers noted that. That was like two different events, the community side and the long-term care side, as Dr. Yaffe's alluded to. And the sense was that that peak has not yet occurred. So there's a delay in the one with the long-term care as compared to the acute care. And if we look at the data around our cases here, as I said in previous conferences here, that while we're expecting those numbers to come down, we have been staying in the I would say the fives, the mid fives to 600 for a couple of days now, but also added into that whole equation as you look at the overall data, about 20% of those are long-term care in the average over there. And if you take that out, that means we're still in the upper fours and almost in the 500 range there. So while we haven't gone up, we haven't come down significantly, and that's of concern as from our public health measures table to say, do we still have significant community transmission occurring? And it would seem that we do. And so therefore, while we've taken the travel out of the equation, and we hardly have any cases related to recent travel, which is only but understandable, the ongoing transmission community would indicate that still people are having events where they're coming in contact with individuals. I'm not meaning our healthcare workers, who of course are required to do so in those contexts of caring for the various patients, be they in acute care ICU or in long-term care and in retirement homes and also in home care settings. But I'm also talking on general. So we have to watch that as we look at our public health measures and where we'd like to see where we can make some changes in the future. But looking at those numbers, we'd like to see those community-based numbers coming down extensively. And we've talked about when we flatten the curve, and we have. We're sort of on this plateau at the moment, and which is better than what was predicted with the original modeling, where by now we should have been up to 1,000 to 1,200 new cases a day from the community. And of course, we have not seen that. So the modelers were satisfied that we have leveled, and we're leveling, and yet I can't say we've peaked and come down yet. So we're still watching those numbers carefully in that regard. As Dr. Yaffe alluded to all the things with the long-term care, we are monitoring our other systems in the retirement homes as well. And we have about 65 that are in outbreak at the moment, and they have about 464 confirmed residents, and they've had, unfortunately, 5 related deaths in that regard. So we're monitoring that. At the same time, we're looking assertively at other congregate settings in the community. Our local public health departments have moved in alongside a number of them already on a risk-based assessment, and we're hoping to have some more succinct and clear guidelines in regard to our wide variety of congregate community groups like homes and other ones in the various parts of our municipalities and in the province, so that we can see how we can move alongside, protect them, and assist in helping them to carry out the proper infection prevention control practices that they would need to deal with their various settings. And of course, we want to do so on which ones are at risk more than others in that regard, as well as looking at our ongoing work with SolGen and the correctional facilities as well. So there's many different parts to be dealt with in this. So while we have a sense of having gained a reprieve in the, at least at the moment, in the acute care, in the ICU numbers, that gives us that venue to try and move forward with other aspects to prioritize even further on long-term care, retirement homes, and congregate settings in the community as we seek to flatten the curve on all lines there and do our best in that regard. So with that, I'm going to hand over to the media for questions.
Okay, we'll move to the phone lines. We'll take questions from the first caller.
First question comes from Mike Crawley from CBC News. Please go ahead.
Hi, doctors. We've been hearing you talk about benchmarks for reopening, and I realize that it's unclear to say what date Ontario could start to move to reduce restrictions. But could you talk a bit about what the actual benchmarks are that you have in mind that the province would have to be hitting to start to consider some sort of changes to the restrictions?
Thank you, Mike. And it's a part of our discussions we're having with our public health measures table under Dr. David McEwen and others from the around Ontario, with other experts to look at and saying what could those metrics be in Ontario that would give us evidence base towards making a decision. I'm not sure there's any metric that would be, when you hit this, you can flip the switch. I think it would be more informed of where we moved either over the peak and coming down. And as I was alluding to at the outset, our data shows us from the modelers and our own data that in the community side we haven't peaked yet. We've sort of leveled and we haven't started coming down the other side. So one evidence is that as we progress, WHO has certain standards. We've seen some others from the USA and various other sectors, so we're doing the jurisdictional scan. We're also at the table at our federal, provincial, territorial meetings, and we're having those discussions live time. I actually left a meeting to come here for that, and they're looking at what would those metrics and numbers be, and we get into terms like R0s and RTs, those are fancy ones, looking at evidence of transmission within the community with case contacts and numbers. So there's a number of things in there. We do want to see evidence that the case community-wide transmission has been curtailed significantly. We want to make sure that our case contact management is back into a containment type modality in those lines there. Now, those are not exact numbers, and I don't think we should be tied to an exact number, but I can say at this moment, and of course in discussion with our command table with our minister, that when we're dealing with daily numbers of well over 500, we're not there yet, and we're looking at how we would look at these in almost like at the, as I've been saying all along, we have these 2-week periods. And we finished our last 2-week period. We start another one on Monday. And this is where we look at how do we sense in the next 2 weeks if we are going to have sustained impact of our public health measures, especially in the community spread side, so that we can start to look at changing some of those directives. So that's the next 2 weeks, because anytime we take a measure, it's going to take a period of about 2 weeks before we say, okay, it's had an impact or not an impact, just because the organism, its incubation period and aspects there. So I haven't given you an exact number, and but I've given you a general parameters of what we're going to be looking at, and we're hoping for some more definitive ones from our public health measures table, as well as from our federal, provincial, territorial group, as we try to see if we're consistent across Canada on how we're approaching the issue on a pan-Canadian basis.
Okay, we'll do a quick follow-up.
One of the parameters that has been suggested by the World Health Organization that jurisdictions need to look at is whether the system's equipped to do fairly widespread testing and surveillance. How confident are you that the system, Ontario system, will be robust enough for monitoring fairly widespread surveillance of cases in a couple of weeks or 4 weeks, whenever you're at the stage of being ready to lift some restrictions?
Mm-hmm. Well, that was on the point, and I think what they said in the WHO, that they would have all contacts of all cases would be understood and mapped epidemiologically. And so the key is not surveillance, it's case contact management. And therefore, part of the whole thing we have to look at is not only, as we've done already, our ICUs and intensive cares and ventilators, are we ready to deal with the surge? And we've demonstrated we have. Next thing is the other systems ready for that, including our public health systems? Are they ready for doing the intense case contact management? Not in the next few weeks, because of the way this virus works. We're going to have to doing that steadily over the next 6 months to a year as we seek to watch how the virus may come back into the community time to time. But can you make sure that you have back into the containment mode the testing, but the testing combined with case contact management, and so you can map all the cases attached to it, or all the links attached to a case, and watch those as well, so you can contain it within either 1 or 2 individuals, small groups, or if in a setting, and not spreading out to the community at large again. So in that sense, we would agree that that's very vital, like the WHO has noted in that regard.
Next question.
Next question comes from Rob Ferguson from the Toronto Star. Please go ahead.
Hi, doctors. Nice to see you both back. Just wondering, just to follow up on Mike's question, what do you think of, we keep hearing that two weeks of no new cases is something that you need to see. Is that what we need to see in Ontario?
I'll let you handle that one, Dr. Yaffe.
Well, thank you. I mean, that would be great. It's probably unlikely to occur, certainly in the near future. I would say that, that is not, like, we can't wait till we get no cases for 2 weeks. We may be in our current state for a very long time if we do that, but we do need to have a very good system of active surveillance and identifying cases, as Dr. Williams said, particularly in the community. Right now, our testing is very much focused in the long-term care and retirement home and probably other congregate settings, in addition to the testing done in the community. But we need to also look at increasing testing in the community as we go along and making sure we have the capacity, both testing, public health, and healthcare, to deal with each case quickly and follow up all the contacts quickly. I think that's more of the criteria than waiting till we have no cases for 2 weeks.
Follow up?
Yeah, thanks, doctor. In terms of follow-up, do you need, is there a number that you need to see? As Dr. Williams was just saying that, 500 is too many. Obviously, it's not in decline. It's kind of flat. Do you need to see fewer than 100 new cases a day or 200? Is there a ballpark where you think that we are getting into the territory where this can be done?
So we were looking at where we were almost when we're in the containment mode back in that day. That was before we had the whole influx, before March 13th and we felt that we were fairly on top of all the case contacts, but already there we were drifting into where we found more and more people that we said when we found them cases, they said they didn't have travel history, they had no history of a contact of the case, and that went from a few percent up to 49 to nearly 50%. That means we had people in the community that had no idea where they got it from. That does not work well with case contact management. It doesn't work at all. So we need to get that number. Then we were in the 200s, the low 200s back then. So we have to get our community numbers. Let's see, we're going to try and extract the long-term care numbers out of there because that's a whole different undertaking. And to get that number, we have to see it not only at the level and start to come down, but come down fairly significantly in there and then get a sense, and because you hear numbers like R naught, and that's where you hear that the number of cases attached to an index case is like 1-to-1 or below that. So you're actually reducing not community spread, but just staying stable or going below that. That's not going, as Dr. Yaffe said, down to no cases in 2 weeks. But it means that those cases that are coming up, that your public health infrastructure can follow all those individuals, follow the contacts of those individuals, rule them in fairly quickly so that you're containing it within either just a person, within a small unit, within a setting fairly quickly and timely so it doesn't go about in the community. So the exact number is certainly a lot less than 500. And I think we'd have to see ourselves back down that, at least in that 200, if not lower, but there's some other metrics we're going to have to put at that time. So we have to see some real ongoing change, and that's why Ontarians have done a great job of flattening the curve, of bending the curve, but now we'd like to see it actually coming down. And we think we have to stay at the true course now for the next 2 weeks to see how much we can really impact that. That means don't get casual on those gatherings. We don't want you to start easing back. I know it's been tough. Everybody's been doing their best in this, and I have been impressed at how much I think the Ontario public have embraced this concept and gone the extra step of maintaining that. And so I think the group collectively, Ontarians collectively, do not want to see us have to go and then backtrack again because they put too much energy, time, and commitment to get where we are today, and so we don't want to have that wasted. So we'll keep watching that, and we'll inform when we think we can do anything on there, not with the risk of having to then do an about turn and get back to where we are right now or even worse. So we're going to be very cautious about how we roll that back.
Next question.
Next question comes from Allison Jones from the Canadian Press. Please go ahead.
Hi, Dr. Williams. We're obviously hearing that now is not yet the time to start easing up on restrictions, but we've heard from the Premier that the province is working on a framework of how to get everything reopened when it is time. We know also that he pretty much doesn't act unless he gets advice from you. Are you looking at any one particular area as being especially easy or perhaps less risky as kind of the first step in easing restrictions?
Well, you're asking me to get ahead of our group in that. I think they're laying the framework out that we would start to look at and approach it, and that would be combined with our health ones leading, as the Premier has noted. While it says from my advice, but my advice is from all the advice I get from all the experts, and collate that and give that together up through the command table to the Minister of Health and then on into the Cabinet and the Premier included. So to give them that guidance and direction. So I can't predict exactly what that will be at the moment. We know that already there's some things that as we head with essential services that we said you can do. If right now that doesn't have any risk. You maintain your 6-foot distancing. You do not have that type of contact, and you maintain that safety level there. But beyond that, we're going to have to look at that very carefully, as I said, because if you give on something and it doesn't seem to be consistent, and how does it fit with the overall public's perception? How's that going to be dealt with in a whole way of, as the Premier said, it's a very complicated thing to restart the province and the economy, and it's one that I know the Premier and the Cabinet and our Minister takes very seriously, and will want to have it done carefully and consistently, and again, as the Premier's insistence, that we're not going to be going forward and have to do about turn back again. He doesn't want to see that, the Minister doesn't want to see that, I don't want to see that, and you don't want to see that. So we're going to be working on that, but I can't give any specifics at this time.
Okay, we'll take a quick follow-up.
Yeah, just quickly, I apologize if this is a number that you already said, but of the 551, I think, new cases today, are you able to say how many of those were community?
Yeah, those two there, the long-term care, that's all you got.
Yeah, I think it's the general. I'm gonna go.
So we don't have the exact. We do have the fact from our long-term care data that Dr. Yaffe was alluding to between the residents and the staff. It comes down to about 74 cases. Now, it won't be direct arithmetic, but you know at least a good portion of those ones in that 500 are in that range. As I said, the overall data is about, averages about each day about 20%.
Actually, so the actual percentage from the IFAS data is 30.5% of the
Today.
cases, community transmission. But you have to keep in mind that for about 41% we don't know. The information is not available. So of the ones we know, 30%.
We're asking on community transmission, or how much is community as compared to long-term care? I thought you were saying what other numbers of the 550, how many are long-term care and how many are community? Is that what you were asking?
Yes, sorry, community versus long-term care, as you've broken out in previous days.
Right, and I said my administrative data would say about at the current one, because it's not exactly in sync with the IFAS data, 74, but I think if you take the idea that it's about 20%, so at least around about 100, probably the overall is due to long-term care. That's just a percentage on the overall data percent there, and we're trying to get those two really in sync if we can, so we can be more exact. But the new long-term care data today is 74 new between residents and cases, but that's theirs, plus we have the backlog of some of the ones being put into IFAS in there. So it's the 550 is an IFAS data, the 474 is administrative long-term care data. I would say my average is about 100 of that 550 is somewhere in that range as long-term care. The remainder is community, which still puts us in the mid-400s.
Next question.
Next question comes from Alison Martel from Reuters. Please go ahead.
Allison, can you please take your phone off mute if it's on mute?
So sorry. So where there's community spread happening now, where is that? Is that workplaces that are still open, particular industries, social contact? Do we know?
It's probably all of the above, but particularly social contacts, people I mean, some people are still working and going out, and they need to. So it's a small percentage, but yes, it's still happening.
Mm-hmm.
Follow-up?
Do we have any cases going to school or childcare either before the closures or for the small number of sites that are still operating?
At this time, I was asked that question because we've had, remember, some of the Board of Education child care centers have opened to deal with essential workers. We reviewed that. I've had no cases reported in that regard and by local medical officer of health or otherwise at this stage. So no, I haven't seen that, and we haven't had the reports. We're actually waiting for a detailed or a fairly quick report worked up by our federal counterparts looking internationally as what is the contribution of children to the COVID-19 outbreak, and therefore then what is the contribution of children in school to that regard. And we're looking forward to hearing that report and see if it gives us any further information, because the data thus far has been fairly limited in that regard, and that's a question whether children, do they actually pass it on? Are they very symptomatic? And the answer is so far not very symptomatic thus far, but they could still be vehicles of transmission even for a short period of time. But the data is not sufficient yet that I've seen, and we're looking for our federal counterparts with the international community to give us some updates in that regard.
Okay, we'll take questions from the next caller, and it'll be our last caller.
The last question comes from James Moore from News Talk 1010. Please go ahead.
Hello, everyone. I wanted to ask, do you not think then it's a bit premature? I mean, obviously you're having discussions about it at that command table, but is it premature, the talk so far about opening up sectors of the economy, given that, judging by how you're talking, we could still be in for quite a few weeks or possibly months of social distancing measures, at least similar to what we're seeing now?
Well, yes, and I think in that regard, the discussions we're having is at the high level, framework level, in that we need to start that early to do the thinking about it, because as everybody says, and the Premier especially said, restarting is going to be more challenging than closing. And you need a lot of lead time from the different sectors to look at the many components, because it's not just simple turning up a switch. There's a lot of things you have to do in series and cycles, so it's going to involve all parts of government and groups in decision making. Therefore, the thinking about that can never start too soon, because even if you have a lead time of 2 to 3 or 4 weeks, that is still in some times not enough lead time. So I think the discussion needs to take place as each sector has to look in their own regards, and the government as a whole on how taking the direction and advice from the Ministry of Health and from our public measures group on how they might incorporate that into a comprehensive, well thought out and sequential plan.
Okay, we'll take a follow-up, and this is the last question.
Okay, so one day the pandemic is going to pass and we'll be widely inoculated against COVID-19. And I wanted to know, when that day comes, would you support the idea of changing the culture and the etiquette, I guess, in this province when if you are feeling sick or if you feel like you have a cold coming on or a cough or a stuffy nose or whatever, do you think that the expectation should be that if we're going outside of our homes that we reach for a mask and wear that outside?
Well, in that day, when we get there, there's no doubt, just like with some other major events in the past, and this has been a major event globally in Canada and Ontario particularly, people and Ontarians in general will probably change their behavior and their expectations and some social norms in regards to dealing with personal hygiene aspects. We've always been big in Ontario with our cough etiquette and it's coughing in the sleeve, etc. Staying home if you're sick. That will be probably even more aggressively put in place in that regard. And I think there may be some others. How that will be as far as our society, and of course our society is multicultural, and it is impacted by a lot of people from their home communities and other ones, not home, but their original areas of origin. And so there's a lot of cultural things blended in there too. So I'll be interested to see how it plays out. There's no doubt for the next year, while we may restart some things, as I said earlier, it's probably going to be that combination, you can, but it's yes, and there's a caveat. And I think the public will be expecting all those caveats and those buts, if you may, added to those things, saying you have to put this, keep this in place. And I think the public are going to be asking for that to be included in those recommendations that may be embedded in a new cultural norm. But let's wait and see. That's still a while off. I'd like to get out of this current one and even to get a breath before we go into the fall to see if there's any secondary waves and to continue to see if we can not only contain it, but keep it out. But that's a plan, that's a vision, and I think we've invested in it. I think we can keep going at it. I think we'll be there in that day. And then if it becomes a discussion later about cultural norms and change, that would be a nice discussion to have, and good to have this behind me, but all of us. So let's stay tuned.
Thanks, everyone.